going to talk about the genetics behind cancers and some of the genetic testing that we do now. I know a lot of people hear about the BRCA gene test is a very common one that people hear about, but there's plenty of others. And so she's going to talk about that. So that should be interesting as well. And it'll also be interesting to have an outside speaker join us. And then next Friday, Dr. Moskowitz, who's one of our clinical psychologists, and Dr. Holmes, who has been here before, are going to do a talk on implicit bias. I know there's a lot of stuff about that in the media right now. And actually on the email that you got, there's a link to do a self-test before the talk if you have time to test your own biases. And I thought this was really interesting. I did this a few years, maybe when I was in medical school, implicit bias test. And we all think that we're not biased, but I looked at the link, it's a link from Harvard, and they have like 10 different categories. So it's on race, gender, weight. I don't remember them all because some of them were sort of subtopics of each other, but there were a lot. And I think you could pick and choose which links you want to do. So it's kind of interesting to test your biases. Time to get yourself in check and realize that maybe, you have some things that you hadn't really thought about. So I think we have a little bit of a small crowd today, which is actually nice. So you guys can join us more actively in the QA and the chat section. So again, for those of you who just joined, I'm Dr. Tanno, and this is Dr. Council, and we are actually both family medicine physicians at Rockville Internal Medicine. Peas in a pod with Dr. Cowan, I guess. And today we're going to talk a little bit about health disparities and race. And one of the great things about having Dr. Council here is that she actually has a master's in public health. So she spent 1 year or 2 years? 2 years, 2 whole years studying population health. So I'm going to lean on her a little bit as the expert here. But we're going to talk about some of the health disparities that we see in different races in this country particularly. So I will let Dr. Council get started, introduce the topic, and then she and I are going to kind of present a whole lot of data here on statistical differences between different groups. And then please do put in some questions. We're hoping that this stimulates some chat. I know that this has been a lot in the news recently. So Dr. Council, take it away.
So like Dr. Tanno said, we're going to be talking about health disparities in race. And really, we thought this would be a great time to talk about it just because of everything that's been going on in the media with COVID-19, but then also some of the race tensions that are going on. So we thought this would be a good time. So on the topic of COVID-19, so we're seeing that, African Americans, minority populations, Hispanics are disproportionately affected by coronavirus. And so I wanted to give some of those numbers. And let me start off by also saying that most of this topic is really just going to be numbers, giving you some of the statistics, and then we'll kind of get into the why and, how we can address some of these things. So when we're talking about corona.
Sorry, can I just interrupt you for a second? There's some feedback coming from somebody. So if you are not muted, please check your mute button right now, just so that the rest of us can hear a little bit better. I think there's a few of you. I don't want to call you out by any means, but I can see there's about 2 or 3 of you. Oh, no, actually, almost everyone is muted. Travis, can you mute? You're also one of the unmuted ones, I think. Travis is our IT support person. Anyway, all right, go ahead.
Okay. So when we're talking about numbers for coronavirus, so African Americans make up about 13% of the United States population. However, make up about 28% of COVID infections and about 23% of COVID deaths. So it's about 3 times the rate of Caucasian American deaths. For Caucasians, it's about 20.7 per 100,000 Caucasians have been diagnosed with COVID-19, whereas for African Americans, it's about 50.3. Hispanics, it's about 22.9, and Asian Americans about 22.7. And these numbers are actually higher in minority counties or cities. So even here in the DC metropolitan area, African Americans have been diagnosed with COVID at a higher rate. So there's a higher incidence of COVID-19 in African Americans. However, the death rates are also higher. So here in DC area, the death rate is about 6 times that of Caucasian Americans. So as you can see, there's some very, disproportions amongst the races with even COVID-19. So before, we even get started in all of these different numbers, let's talk about what exactly is a health disparity. So it's the differences in health outcomes within a population based on either ethnic, racial, demographic, social, cultural, geographical, environmental factors. And so, like we said, with COVID-19, we're seeing that, minorities are being more affected by COVID-19. But when we start talking about some of the risk factors, one of the things that, you're hearing on the media is that we're saying, if you have underlying medical conditions or chronic medical conditions, that you may be at increased risk. And so this talk will really talk about some of those underlying medical conditions, such as hypertension, diabetes, obesity, all of those different things, and how in every aspect of that, we're seeing that minority populations are disproportionately affected by these numbers. And so this is why we have this issue with COVID-19 right now. So I'll let Dr. Tanno talk a little bit about some of some numbers.
Wow, I just want to take a moment because I hadn't heard that even in DC that African Americans have 6 times the death rate as Caucasian, DC residents. That's staggering, really, if you think about it. And I know later Dr. Council is going to talk a little bit about when you actually adjust for socioeconomic differences, how a lot of these changes actually don't go away. It's easy to say, oh, well, those people probably live in a place where they don't have great access to care and that's why they die more. But actually, in a lot of these cases, when we get further into numbers, it appears that that even when you adjust for that, that the change is still, the difference is still there. So like I said, we're just going to start with an introduction of a lot of different statistics in different sort of categories. So Dr. Council just talked about some of the COVID changes, but also, in primary care, a lot of what I do is blood pressure control. And for those of you who are tuned in, blood pressure affects 1 in 3 adults. So there's a very good chance that if you're sitting here listening to this talk, that you are affected by elevated high blood pressure or elevated blood pressure, which is medically called hypertension. But what we see is that the ethnic and racial minorities actually have higher rates of morbidity and mortality due to these high blood pressure. So more likely to have strokes and heart attacks, for example. And then if you look at the prevalence of high blood pressure in Black Americans, it's 40% versus 27% in whites and Hispanics. So they are at increased risk of high blood pressure. And then if you look at Asian Americans, they actually have a 25% prevalence, so a little bit lower, but they're more likely to have uncontrolled blood pressure even when they're on medication. So 33% of Chinese Americans versus 24% of Caucasians have uncontrolled high blood pressure even on medications, that their medications are not either dosed at the right doses or they're not in the right combination. So again, high blood pressure affects a ton of Americans, but disproportionately affects some of the minority races.
That's important because, like we said, when I just was talking about COVID, we're talking about, underlying health conditions. Hypertension is one of the things that they talk about, hypertension. And so if we're seeing that, these minority populations are having higher numbers, then there's no surprise that, when we're looking at these numbers for COVID-19, that we're seeing higher numbers in those minority populations. So let's talk about diabetes. So diabetes is increased amount of sugar in the blood, typically due to, diet. Sometimes it can be genetic. So when we're talking about diabetes, the numbers are showing that Pacific Islanders and American Indians have a 33% prevalence of diabetes, which is actually one of the highest prevalence amongst ethnic groups. So when I'm talking about different ethnic groups, it's really, most of these studies are based off of the various ethnic groups that the US Census looks at. So that's going to be non-Hispanic whites, non-Hispanic blacks, American Indians or Alaskan Natives, Asian Americans, Native Hawaiians, or other Pacific Islanders. So out of that, out of all of those different ethnic groups, Pacific Islanders and American Indians have one of the highest prevalence of diabetes. In addition, so Native Hawaiians, which would be in that group of Native Hawaiian or Pacific Islanders, those living in Hawaii, they are 5.7 times more likely to die from diabetes compared to non-Hispanic whites that live on the island of Hawaii. Filipinos are 3 times more likely to die from diabetes. So this is not just a black and white issue, it's more of a minority issue that we're seeing with all of these health disparities, is that we're seeing that minorities are disproportionately affected by a lot of these medical issues. The prevalence for diabetes in African Americans, 12.6%, Hispanics, 11.8%. However, African Americans and Hispanics are 2.3 and 1.5 times more likely to die from diabetes compared to non-Hispanic whites. But when we think about, when we're talking about Hispanics or Asians, you have to also remember that some of these numbers may not be 100% accurate for each subgroup. So when we're talking about Hispanics, we're talking about, you know, South Americans, Cubans, Mexicans, those that are descendants from Dominican Republic or Puerto Rico, but then we're also talking about Mexicans, Central America. So the numbers can be very, very different and higher in certain areas. And so for example, South Americans have a lower rate of diabetes, 10%, Cubans, 13%. Whereas Mexicans, Puerto Ricans, those from Central America or Dominican descent have higher rates, between 16 and 19%. And then we're talking about Asians whose rate of diabetes is around 7 or 8%. So there's a huge difference still between all of the different subgroups. When we talk about Asian Americans, typically diabetes prevalence is around 8% for Asian Americans. But once again, that's a very large group when we say Asian Americans. We have to consider those from Southeast Asia, such as Cambodia or Vietnam or Thai, but then it also includes South Asian, which are typically those who are Indians, East Asian, those from, you know, with Japanese, Korean, or Chinese descent, and then also Pacific Islanders, such as Filipinos. And when we look at those rates, Asian Indians have the highest diabetes prevalence rate, around 14%. And Asian Americans from Korea, Japan have the lowest rate, around 4 to 5%. So their rate is actually a little bit lower than Caucasians, where I said it was around 7 or 8%. So you can see that there's a vast difference among even the subgroups of all of these different ethnic groups. And that's something that we need to consider as physicians when we say, you know, well, where are you originally from? You know, tell me about, you know, who's in your household, where do you live? Because all of that really does make a difference when we're talking about health disparities and how we really should be addressing some of these things.
And I know that you wanted to get into some of the reasons for these differences later, but I mean, I guess, and I'm happy to wait for that, but I mean, those numbers are very different. How much of that do you think is genetic versus cultural, like, lifestyle differences?
So it's a mix. So when we talk about health, one thing that we need to realize is health is not just our physical health, but it's also, you know, social well-being, as well as, you know, mental, emotional, all of that plays a part. Which is why, like I said, like, you know, when we ask questions about social history, you know, we're asking about, you know, geographic location and all of those things. So it really is a combination of everything. So some of it is diet, which is why, you know, we'll counsel and say, hey, make sure you're changing your diet. Some of it is genetic. You know, there are some patients that are very, very fit, but still have high blood pressure or still be, you know, pre-diabetic, despite the fact that, you know, they eat well, they exercise, all of those different things. And some of it really is, you know, just due to circumstance. So socioeconomic status. So when we talk about socioeconomic status, that's really one of the strongest determinants of a person's health. And it really, you know, so there are some numbers I have that I wanted to go over, because when we talk about that, we're also talking about, you know, what is your income like? Can you afford the medication and all these different things. So there was a report from 2018 that said that 38 million Americans live in poverty.
Wait, sorry, I think you cut out there for a second. What percentage?
38% or 38 million, which is 14%. So 38 million Americans live in poverty, which is 14% of our population. But with that, also, you have to remember that includes 15 million children. So let's even talk about the fact that right now schools are closed because of COVID-19. So we have these children that may not have access to getting, school breakfasts and school lunches and things of that sort. So that's a whole nother issue that we have into play. And depending on the neighborhood that some of these individuals may live in, they may live in what we call food deserts, where there may not be a grocery store. And instead there's, a corner store that may not have, access to fresh fruits and vegetables. So now we have patients that are relying on, boxed foods or pre-prepared meals, or, going to a corner store to try to get, some type of food, which, we know is not going to be the most healthy food, which comes into play with increased risk of diabetes and high blood pressure and all of those different things. And when we talk about children, that's why we have this obesity epidemic going on right now, where we're concerned that childhood obesity rates are on the rise. And a lot of that may be due to the fact that we have 15 million children right now in the US that are living in poverty. So it's really a complex issue when we say, well, why are all of these differences occurring amongst ethnic groups? Because some of it is also cultural in terms of, like you had mentioned with some Chinese Americans, that although that they may be on hypertension medication or blood pressure medication, that it still may not be well controlled. Some of that may be cultural in the fact that they, may believe that, they may want to try teas and herbs and things of that sort. And some of that may interact with medication, and some of that may be that, I'd rather take this instead of taking a pill. And so there's a lot that comes into play when we say, why does this occur? But we really have to look at the whole patient to really try to figure out, well, how do we address these issues to try to disparities?
All right, well, let's talk a little bit more about statistics, then we can come back a little bit to the why. So we've been talking about COVID differences, high blood pressure differences, and diabetes differences. Another area where we see discrepancies in health across races is overall in the United States is in breast cancer. So overall, 1 in 8 women in this country will be diagnosed with breast cancer in their lifetime. Now, for those of you who are listening and that number scares you, there's different kinds of breast cancers, there's different ages, there's all kinds of things, but overall the number is 1 in 8. And the incidence of breast cancer is highest among Caucasian and Black women, 13 and 12%. That's where they get the 1 in 8. However, white women are more likely to be diagnosed with breast cancer, possibly due to better screening, unclear. And African-American women are more likely to die of breast cancer. And then, so that's probably a combination of access to healthcare, access to screening, access to awareness, even education too, but there's also a genetic difference. So when we talk about breast cancers, you might hear people say that they're estrogen or progesterone positive for a certain, it's a subtype of the breast cancer, it's how they're classified, and treatment options are determined based on people's hormone picture of their breast cancer. And so there's one type that's called triple negative breast cancer, and that's a more aggressive type, and that's more often found in younger African American women. So that probably has more of a genetic component per se than a screening, access to screening. And some more statistics here: Asian American and Pacific Islander and Hispanic populations have an 11% incidence of breast cancer, so that's about the same. And American Indian and Alaskan Native have the lowest lifetime risk at 8%. So definitely less. So those are some breast cancer differences. And Dr. Council is going to now talk a little bit about prostate cancer and colon cancer differences.
So with prostate cancer, African American men have a 70% higher incidence of prostate cancer, and are twice as likely to die from prostate cancer as compared to white Americans. So for those that, were there for my talk when I, discussed all of the preventive screening and things of that sort, that was one of the things that I talked about, was just saying that, for prostate cancer, we typically, around the age of 50 or so, we may just have the discussion with men with their annual wellness visit to discuss, screening and things of that sort. However, with African American men, we typically start that discussion a lot earlier, typically around the age of 40. And this is the reason why, because there's a higher incidence of prostate cancer in the African American population. In addition, with colon cancer, so African Americans have 20% higher incidence of colorectal cancer as compared to Caucasians, and 50% higher incidence as compared to Asian Americans and Pacific Islanders. So the mortality for African Americans from colon cancer is 40% higher than Caucasians and 2 times higher than Asians and Pacific Islanders. So once again, we're talking about, drastic differences across all of these different, health these medical issues. We're talking about, drastic differences across all of them. And, it's something that we definitely take into consideration when we see our patients. American Indians or Alaskan Natives have the highest incidence and mortality of colorectal cancer in the US, 91 per 100,000. Mortality 37 per 100,000, which is 80% higher than African Americans and more than double that from Caucasians. So some of that, like you were saying earlier, could be diet, some of that could be cultural, some of that could be geographic location. There's so much that goes into this. But as you can see, it's something that, we have to pay attention to. So, I said that when we talk about health disparities, we're not just looking at the physical health of a patient, but we're also looking at social and geographic location and, what type of interactions they've had. Stress also, can contribute to some of this. In addition to the fact that education, we know that education is the second largest influence for life expectancy. So for those that may have, a lower educational level, then some of these things they may be at a higher risk. So if you are, African American and, you have a high school degree, but no higher education, and you live in an area where you may not have access to, certain grocery stores and things of that sort, then it is no surprise that we may see that you may have, diabetes and high blood pressure and all of those things. So once again, that is one of the reasons why, we ask patients, where are you from and how long have you been here and what type of work do you do? It's not necessarily to be nosy, and it's not necessarily, to make patients feel uncomfortable, but it's also for us to understand some of what we call your risk factors. So it's the same reason why we ask about family history. Tell me about your parents or your grandparents, siblings, things of that sort, because all of that helps us to know, should we be screening you earlier for certain things? What should we be doing to try to help decrease that gap or make it so that you, are not one of those people that may have a higher number or be, one of those when we're talking about the prevalence of these diseases.
Can you, sorry, there's like always a delay within unmuting. Can you talk about which of these differences persist after you adjust for socioeconomic status? Because I think that really, sheds light on some of the disparities. I know we had talked the other day, and you had mentioned like maternal and infant mortality. So if you can just talk about some of that.
Sure. So when you and I were talking and kind of getting this talk together, we were talking about that. So with maternal mortality, we know that Black women are 2 to 3 times more likely to die from pregnancy-related causes as compared to Caucasian women. And the example I gave you was myself as an African-American woman, educated with, my MD, MPH, I am still 2 to 3 times more likely to have complications associated with my pregnancy as opposed to a Caucasian woman who may have a high school diploma. And so that is one of the statistics that is across the board. It does not matter. In addition, most of these, besides diabetes, the number that we talked about for diabetes was that the prevalence in African Americans is around 12%. When we talk about, adjusting for socioeconomic status, it goes down to 10%, which is still higher for, Caucasians and Asian Americans. So despite adjusting for socioeconomic status, there's still a big issue with having this. And so, with having these disproportionate numbers. And so that's something that as healthcare providers, we have to be aware of, but also, just the patients that are right now listening, just knowing that, hey, my neighbor is at increased risk of this. And, maybe I should say, let's get out and walk. Or as a community, it's something that we all need to be aware of.
Yeah, I was actually listening to, there's a podcast called the Health Disparities podcast, in case anyone's interested. And they had talked about the maternal rate, but they had also said the infant mortality rate is about two times higher in the first year of life for an African-American infant to die versus a white infant. Which and that they said basically like even and that's adjusted for socioeconomics. So they were saying how even a baby of a educated African-American woman is 2 times more likely to die than a baby of a white woman who, say, has an 8th grade education, which that tells us that we have a long way to go. There's a lot of reasons behind this, and we can get into it a little bit, but is it that when they come to the hospital, healthcare providers are less likely to believe the symptoms? Are they more likely to be sent home from the emergency room with certain symptoms because they say, oh, it couldn't possibly, this is just whatever kind of prejudices people have or assumptions people have, is that even the reason behind that? Is there more to it? But I think what's interesting here is the connection between genetics and social determinants of health, basically the income and education. So, we wanted to talk to, these numbers are a little depressing. So, Dr. Counts and I were talking about some big ideas here about how do we address this? And I think that's a lot of probably what's going on right now with the riots and the protests and everything is this is a big issue to tackle. It's not easy, these health disparities. How do you even begin to approach them? And I think what's important to notice is how complicated this is. This is not just, oh, let's give everybody, better housing, or, oh, let's just give everybody universal health care, or, oh, let's just fix racism. These are all interconnecting things. And so there's no one system you can fix without that would totally fix these health disparities. I think we'd have to work on the healthcare system. Of course, access to care. If you have access to good medical care, you're more likely to get your regular screenings and be diagnosed with something early and on time. You're also likely to get better treatment if you have access to care. If somebody does not have health insurance or has a $10,000 high deductible insurance plan, they're not going to get the kind of care that somebody who has, good insurance or very, very affordable insurance. So there's definitely a healthcare picture here. Social work and case management issues. So, like Dr. Council said, those kids who are normally in school who are getting free and reduced lunches are not getting those now, and that contributes to their mental and physical health. If you are hungry, you're not able to focus, you're more likely to do poorly in school, which also has negative health outcomes in terms of education and lifespan. There are environmental conditions that we could work on. If you look at levels of smog, say, in certain parts of the world, those contribute to asthma rates and other conditions. There's environmental factors here. There's a lot, and basically to get changes in these health disparities, it has to happen from such an enormous level. I mean, really from the top down and the bottom up. I mean, this would be a grassroots and a big government kind of thing, affecting policy, affecting, you know, where people live, where people go to school, access to care, all of these things. And so it's very hard to fix these kinds of disparities. I don't know if Dr. Council has any specific comments towards that. I'm sure we could talk about this alone probably for like, you know, 10 years, but.
I agree with you. I mean, it's a complex issue. But I think the one thing as individuals that we can really do is kind of like you said, the talk that Dr. Moskowitz and Dr. Holmes is going to do next week. I think that that's really important, you know, is for us to check our own implicit bias. And so, like you said, for example, you know, if things are adjusted for socioeconomic status and we're still having these disparities, then we have a systemic issue, right? And you know, to say that, you know, possibly like the example you gave with, you know, African American kids and things of that sort. So is it because, you know, that you know, the provider does not believe the mother? Who knows what all of that plays into? But there's definitely, you know, room for all of us to really say, you know, do we have our own biases, and is that helping to contribute to the problem? And if so, then that's something that we as individuals can work on to at least start to make, you know, some adjustments. Of course, you know, we're not going to make strides by just doing that. There to be done, but I think that's something on an individual level that we each.
Yeah. Do we have any comments from the audience? Any thoughts you guys are having or questions? I mean, I you know, like I said, this is a big topic, so we could cover a lot. And so if there's something that you have questions about, you know, maybe that we could send our discussion a little bit in that direction. Somebody sent a question here. What is the name of the online bias test you had mentioned at the beginning of your session? That link is going to be mailed out with next week's webinar. Actually, I could probably find it and send it. But
I'm looking it up right now. I'll send it.
Did you see it in Dr. Moskowitz's email? Or it's on? Yeah. Actually, I put it in the Google Sheet if you have that.
Yeah, that's what I'm pulling up right now.
Okay. Just post that into the chat. You can, and people can do that later. But they have like 10 different links there for implicit bias. So it sounds like something you could probably play around with for probably an hour at least. Any thoughts or questions? Or is there anything in this talk that surprised people that you know, just would like to comment on, maybe more than a question? You guys are on a Friday afternoon here.
Oh, so Mark said it's called implicit association test.
Okay, here, and then Dr. Council just posted it inside the chat. So if you guys want to look at that link later, that's really interesting. I don't know, I guess, Dr. Council, when you talk about these issues, like, I mean, you went to school for a master's in public health. What about this sticks with you, I guess? Is there anything that like you keep coming back to that you just yourself sort of perseverating on?
I mean, there's not anything that necessarily sticks with me, so to speak. I mean, it's just something that you know, it's not new. It's something that we've known for a very long time. So we know that, you know, here in the US, you know, subpopulations are typically the ones that are more likely to suffer from chronic diseases disproportionately, you know, and that's usually minority subpopulations. And so what I guess if you wanted to say something sticks with me, the one thing would probably be the fact that these differences we're not seeing as vast differences when we talk about other countries. So this is something that we're seeing in the United States particularly, not, you know, in Europe or, you know, in Asia or things of these other places. So that's something also that we, you know, need to keep in mind. These are numbers here, and in other countries, they're not seeing them.
And maybe you know, or maybe you can speculate on why, like, what do you mean? Wait, so maybe give an example of what you mean, because I think maybe just give a.
So in terms of like the disproportionate numbers, for example, or diabetes. Like I was saying that, the numbers here are showing that for African Americans, it's, 20%, or Caucasian Americans, it's like 70%. So, a huge difference there in terms of the incidence of diabetes. And when we talk about diabetes in Europe, same populations, African Americans and Caucasians, the numbers aren't that vast of difference. And so why? I think that's very complex as well. I mean, we could go on for hours talking about why, but some of that can stem in just how this country was built. Some of that, depends on how neighborhoods are divided and all of these different things. There's so much that can go into why we have these issues, which is why I say it's a systemic issue that's not new. But I think that with COVID-19, it's something that people are just realizing when they see these numbers and these vast differences in COVID-19. Like I said, in the DC metro area, we're seeing that African Americans are dying 6 times higher than Caucasians in the DC metro area. So, when you hear those numbers, it's like, wow, what is going on here? So I think that it's bringing light to the fact that we do have a problem with, disproportionate numbers and health, but it's something that has been, a problem for years. For me, as someone who has a background in public health, or even as a physician, as you can see, even in training, just seeing that, the patients that you see and things of that sort, and those numbers, those that are most likely to, have diabetes or high blood pressure or colon cancer and being diagnosed with breast cancer younger and all of those different things. So I don't think it's necessarily new for those in the healthcare field, but I think it's something that, most people most people are not aware of just because they're not in that field.
Yeah, and then Dr. Park had submitted this.
I'm looking.
This comment in the chat. So Dr. Parker is one of our clinical psychologists, and she wanted us to talk a little bit about the lack of trust that exists in the minority community towards authority and medical professionals, and I mean there's a long history of that, and also religion as a factor. So I think this is again, I mean, this mistrust of the medical system is it is well founded. Unfortunately, it comes from a time of where essentially white physicians, mostly white physicians, did, for lack of a better word, experiment on minorities. We saw this with, back in the times of slavery, they would do horrible things with slaves, and then even recently with the Tuskegee Airmen, which was a case where they, well, somebody else might know way more about this history, but basically they allowed a population of Black men to have untreated syphilis to see what would happen over a year. Syphilis is normally treated pretty easily with penicillin. If untreated, can lead to devastating cognitive and neurological deficits and ultimately death. And so they decided to do this experiment. And then if any of you guys have read the book, The Immortal Cells of Henrietta Lacks, that's a fabulous book about doctors at Hopkins who used stem cells from the cervix of a patient, a Black patient, Henrietta Lacks. And it's wonderful. Honestly, if you are looking for something to occupy yourself for the next 3 days, I would highly recommend that book, The Immortal Cells of Henrietta Lacks. But ultimately used her cells for profit and continued to harass her family for decades for additional samples without getting any kind of real consent. So this lack of trust between minorities and the medical community, like I said, unfortunately is well founded. But that being said, I went to medical school in Baltimore, and which is a majority African American population there. And a lot of times I would say, you have new high blood pressure, I'd really recommend starting this medication for you. And the immediate response was, I don't want you to experiment on me, and as a physician, it feels very ungrounding for somebody to say something like that to you, because you would offer this treatment to anyone, and of course you're not experimenting. These drugs are well studied and recommended, but that mistrust oftentimes leads to people not wanting to take their medications, not wanting to come see the doctor. And there's tons of other examples of this mistrust between medical providers and patients, not just in the African American population, but in other populations as well. Also mistrust of certain testing. I recently read somewhere that Muslim women are less likely to undergo colon cancer screening due to some kind of stigma that persists in their culture, which I have not come across in Rockville. I've not, that I know of, but these are things that they don't necessarily teach in medical school, to question a patient who is saying, "Oh, I don't want to get tested," just to say, like, I think sometimes it doesn't come out. Are there other outstanding examples that you think of, Dr. Council, in terms of mistrust that might lead to disparities?
You mentioned a lot. The father of gynecology, Dr. Sims, who considered the father of modern gynecology, the fact that he perfected some of the gynecological procedures that we do now, based on testing and studying and doing these different procedures on African American slaves without anesthesia. And so there's this thought that, or there was this thought that, African Americans could not feel pain and did not need anesthesia. And so even to this day, that's when we kind of get back to the implicit bias, and where there may be more of a mistrust, because sometimes patients, I was actually talking to one of my friends who actually is family medicine trained and did a fellowship in palliative care. And there was this conversation that she was having with some of her coworkers, and they had done a study. And what they found was that a lot of the physicians there actually thought that African Americans had a higher pain tolerance. And so when palliative care, who required different pain medication, they actually thought that they may be drug seeking, things of that sort, although this was not the case. And so sometimes, that's why I said it kind of goes hand in hand with this implicit bias, with making sure that we're really, understanding that. And so when patients have mistrust, it's definitely, founded. I remember when I was in graduate school, and I'd read this study about a group of Hmong, Asian Hmong population. And one of the things that they do for healing is cupping. And when the child went to the emergency department, the physician thought that there was some type of child abuse going on. And so that, a whole case was opened up, and that brought up something completely different. So, just understanding and having cultural competence in the healthcare system, I think, is very important. And so patients have this mistrust because they don't feel like we as providers are as competent as we probably should be with understanding, background and cultural differences, and just being a little bit more patient with some of those things, like you said, where patients may have said to you, I don't want to be experimented on, but, us realizing, well, where is that coming from, and why would you say that? And how do I address that in a way so that you can trust me? I think going forward as providers, that's the one thing we always need to try to build on, is first building trust with our patients, so that, they are more likely to be compliant and things of that sort. Because if you don't have trust, then where are we going to go from there? If they don't trust us, and then, so calling Child Protective Services or all of these different things. Now, of course, we have to, right? Because, that is our job. And so we are legally responsible if we think that there's a case of abuse or things of that sort, but also recognizing and understanding and just being patient and listening to our patients and understanding where they're coming from, so that we can try to at least meet them halfway. I think that's important, especially like with Dr. Park, she asked about like religious differences. Especially in the African American community, religion is something that's really, really strong and strongly rooted. And so a lot of times my African American patients may say, well, I want to pray on it, or I want to wait and see, well, God will move it, and things of that sort. And, I completely understand that, you know, and so we can wait. Let's come back in a week. Let's come back in 2 weeks. If your blood pressure is still really high, we need to do something, you know, and just letting them know that, hey, you know, I understand that, but God also puts physicians and nurse practitioners and PAs in place so that we can, you know, make sure that you're doing well. So just trying to figure out other ways to meet patients halfway to build a rapport and kind of cut down some of those barriers.
Yeah. So I think, you know, the goal of this talk was really to give you some statistics behind health disparities, and then, you know, skim the surface really on the why behind that. And so distrust is one of them. But as we said, you know, there's so much more: education, quality of the air where you live, access to, you know, all kinds of things. So this is not a simple problem to solve. So I think, you know, when we actually go to solve it, just solving something like racism or doing a single payer system, I mean, that won't address everything. Of course, those to some extent, you know, better access to healthcare will help everybody to have better care, and it will help with some of those things like late diagnosis of cancer as opposed to early diagnosis found with screening. But are there any last sort of comments or closing thoughts here? Because like I said, we could probably go about on this for, I mean, I don't know how many thousands or hundreds of thousands of PhD dissertations have been written on this very topic. So there's a lot out there.
Responded to one question. So someone was asking about stats in Canada versus US, and if we had any charts that they can use to discuss with peers. So I can put together some of the graphs and just give it to you, and then you can save it on the website if patients want to use that.
Yeah, we can just do some, yeah, you can do slides. Yeah, but I mean, you know, when you think about Canada, I mean, Canada is a country with you know, universal healthcare. They're also a much less populated country. They also don't have quite the history that we have with races. I mean, I'm sure they have their own, but it's different from ours. So you can't always compare apples to apples in so many of these cases. But I think if that's the end of the questions, I think unless Dr. Council has anything else to say that's urgent, no. I don't, like I said, we could go on this for a while. There's all these different kind of roads you can paths you can go down when you talk about health disparities. It's huge. It's definitely way more complicated. And I think sometimes when you participate in a healthcare system, you see that, like we would see, it's hard to even explain, you know, because sometimes you just want to say, why can't these people just do something different? And it is a very complicated question to answer. But I would recommend the book that I had said, The Immortal Cells of Henrietta Lacks. It's old now. I mean, I think it might be 15 years old, but really gets into some systemic racism there.
Another book I would recommend is Medical Apartheid. It's a really great book.
Okay, haven't heard of that one. So that one, yeah, I mean, there's so much out there. So if you're interested in this topic, you could, like I said, you know, spend the rest of your life studying it. It's very complicated. But let me just tell you guys a little bit again about next week. And just in case you were interested, the links from Privia should be coming out. They're emailed on a delay in batches, so I'm not sure exactly when everybody gets them, but Monday is Dr. Council again with Dr. Holmes talking about the annual wellness visit for Medicare patients. This is a very confusing visit to a lot of people because Medicare in general is very confusing to a lot of people, including myself. And they're going to talk a little bit about that visit, what's expected, how is it billed, what's covered, these kinds of things. And then Wednesday, we have guest speaker, Dr. Shannon O'Connor from Maryland Oncology Hematology. She's going to talk about genetics behind certain cancers. So talking about who's at elevated risk of certain cancers just based on your genes. going to talk about health disparities. She's going to get into some of the genetic weeds. And then next Friday is another talk. Dr. Moskowitz is one of our clinical psychologists, and Dr. Holmes again are going to talk about the implicit bias. So that's where that link for you testing your implicit bias comes in. If you want to do that in advance, I'm sure you might learn something very helpful. Here's the last question. I guess we can try to answer it in about 1 minute, but what should we be asking from our political leaders to help solve this issue? Big question. Council, do you have a 1 minute answer to that one?
To our political leaders, I guess trying to make sure that, you know, everyone has access to healthcare, but also, you know, promoting for some of these grassroots or community organizations, like having community gardens and some of these other things so that people can also have access to healthier foods. You know, I think, you know, at least trying to start that conversation is important, trying to increase access to those that don't have it.
Yeah, I think there's so much there from our political leaders. I think I had talked last week, I had done a talk on adverse childhood experiences called ACEs, and how that contributes to chronic health later in life. And so this can be as big of an issue or as small of an issue. For some of these children, having just a mentor in their life to help them escape some of the issues they have. If you're interested in one-on-one volunteering, there are plenty of programs in DC that will take people and, you know, helping a child who comes from a low-income household, you know, have some self-esteem and finish high school will help their overall chances of having good health later. And then, so that's at the very, like, individual grassroots. There's things your community can do. And then, yeah, as far as the political leaders, I mean, there's so much we could ask of them. I think you just want to maybe pick something that you are passionate about. Is it better access to healthcare? Is it better access to some, like Dr. Council said, the community gardens, access to food and eliminating or reducing what are called food deserts, where people do not have access to a grocery store. Safety in certain neighborhoods. Obviously, if your neighborhood is unsafe due to crime, that has huge effects on your mental and physical health. So many things here. I think, you know, and I think that's where we can't just look at them and say, fix this. We have to really understand some of the complexities behind it in order to understand what specifically we can ask them to do, because yeah, they're like us. I mean, this is in many ways this is a big problem to solve, and there's no one thing that they can do. It's like a lot of big things together that add up. So thank you to everyone for joining us. I will see you guys back on Monday. I'm actually in the office on Monday, so hopefully I'll be running on time. It's a little harder sometimes to run on time when you're actually in the office. So I'll see you guys on Monday. Thank you to Dr. Council for joining us. And we were hoping this webinar would be sort of part of a series of some conversations around health and race. So that's why next Friday there's the one on the implicit bias. But I hope everyone has a wonderful weekend. I think it should be nice weather, and try to get outside and do something a little bit out of your, you know, your routine. You can. All right.
See you later, Dr. Tanno.
Bye.
Bye.